really impressed by the high number of patients which were included in this study. There were about 330 patients. And especially if you do look at the results, it's maybe the first and only, or the first study which met both endpoints, the primary safety and effectiveness endpoint, which shows that the treatment with the DCB is superior to plain balloon angioplasty. That really helps us for therapy decisions in our daily practice.
The data from the study represent a wave of positive for those who have always strongly believe in DCB. 6 months, the primary patency of the target lesion is statistically higher, over 20% rather than the high pressure balloon alone. And the patency of the circuit higher than 25%. This is the fundamental data, in my opinion, is fundamental in this study. Today we have a strong and incontrovertible level of evidence to affirm that the DCB must be the gold standard in the treatment of vascular access stenosis.
In my view, the main highlight from the IN.PACT AV Access trial publication is the better primary patency rate, for about 22% higher than not using the DCB. And this is one of the main improvements comparing the DCB to the plain balloon angioplasty.
Having this data now, it supports the use of DCB in AV access, what we already do. But now we have a scientific proof and background to justify the use of the DCB. And especially if you go into discussion with reimbursement, now you're able to show a randomized controlled trial showing the benefit of the use of a DCB. So that supports our decisions and what we are doing already at our hospital, but now with a scientific background.
I started using the DCB in clinical practice since 2014. And in Varese, the use of DCB has been implemented since then. In my clinical practice, nothing will change, but I hope that this data allow us to highlight an incontrovertible way the advantage of DCB, and that this evidence will be inserted in a world guideline.
The recent publication in the New England Journal of Medicine on the IN.PACT AV study changed the way I decide to use balloon angioplasty. Typically, before doing that, we would do plain balloon angioplasty and see what happens. And now there is a study which confirms that you can use and should use a drug-coated balloon at the first time doing the angioplasty.
Dialysis patients have to turn up several times a week at the hospital or at their dialysis unit, and that also already reduces their quality of life a lot because they stay in there for hours. Every additional procedure associated with a dysfunctional AV access is a problem for those patients. They may be treated as an outpatient or even as an inpatient, and they stay at the hospital, and they do spend even more time to keep their access running. So every procedure which prolongs the intervention-free interval for those patients is really beneficial.
The use of DCB has a fundamental value for the patients in hemodialysis due to lower number of retreatment and HS thrombosis from here. So in my opinion, this generates an advantage for the patients. Maintenance of the HS life and the better quality of life for patients due to reduction of number of days of hospitalization for year.
The data from the IN.PACT AV study will definitely be good for the patients because the quality of life is dependent on how often the patients require an intervention, how often they need to attend hospitals for a reintervention and don't require so many treatments. And attending hospital is always stressful for the patient. So with the data we have gathered from the study, they will definitely have better quality of life.